Good morning, good afternoon, depending on where you are. Good evening. Please feel a very warm welcome from us to this very important webinar, and that we have carefully entitled "From Aid to Ownership" and rethinking primary healthcare financing in Africa. And we are more than happy to have you on board, and for you finding time to be here today, to not just listen to us, to the rest of the team that is here, but also to contribute, because I think we are all in this together. So my name is James Tiriongo, currently serving as the Director of Partnerships at Financing Alliance for Health. Financing Alliance for Health is an Africa-led, Africa-focused organization that works very closely with government in its quest to help governments invest more and better in sustainable health systems, especially from a financing standpoint. So today is one of those very important occasions that we bring together leading voices from government, global funding agencies, and technical institutions to explore one critical question, and that is, how do we sustainably finance primary healthcare in Africa, even in the context of dwindling external aid or donor support? How do we sustainably finance primary healthcare in Africa? That's a topical issue here today. In addition to the leading experts and health system leaders that will be in this panel, but as well from the audience today, I know there's so many others that are out there in this audience who are deeply involved around matters of financing, but as well in thinking through primary healthcare in Africa. So may I ask you to introduce yourself in the chat? Please provide your name, your organization, the organization you currently work in, or if not, even when if you're an individual, it's still very helpful to know where you are, as well where you're joining from. This will be a great chance for us to get to know who is in the room. And I believe we are coming from across the continent and even beyond. So it's really an opportunity for us to get to know who is in the room. A few housekeeping matters. Would love to see your faces. So feel free to put up your cameras. And also the fact that this session will be recorded, and we'll be happy to share the recording after this session that we'll have successfully gone through. But as well, please keep it off if you desire as so. You can post your questions on the Q&A platform so that we can actually pick them even as we go along, but as well address them at the end of this session. So feel free to do that. And perhaps just quickly, just to introduce the conveners of this webinar, FAH. Just a few minutes I would want to spend to just speak to who we are. Like I said, FAH is an Africa-based, Africa-led, and Africa-focused community health financing technical expert, having supported 16 countries so far across the continent since 2015. So we're not a very old organization, slightly over 8 years now, 8-9 years. And it's great to see the various things that we've been able to do in the continent over the short time that we've been around. Our work areas are built around 3 areas of work: country engagement, country government support. And here we are looking at long-term on-site technical and financing support on primary and community health. We also are invested around developing the requisite tools and toolkits to support country costings, investment cases, and being able to design financing pathways. The third area of work is actually designing financing products and modalities. One of those is actually the Africa Frontline Fest. And here we work with donors, and financing industry players to design, develop, and deploy new modified financial products that are context-specific, but also solve for the challenges that we face across different governments in the continent. And lastly, looking at awareness as well as education. And here we're looking at communicating case for investment, building thought leadership, and sharing capacity building material as part and parcel of the bigger shared learning agenda. So that's FAH, and we are more than happy to have us convening, and really glad to have you on board. So why this conversation? We all know the situation we are finding ourselves as players in the health sector, and more specifically around the primary health care across the continent. So just like the iceberg captures the moment where we see, we only see the surface, the tip of the iceberg. And that is defined by a shrinking donor the support, given what we are seeing in the landscape at the moment, shrinking ODA contributions to solve for more things that are more domestic in donor countries, so to speak. But that's only the tip of the iceberg. And it begins to speak around what is visible, but also what is urgent, which is important to look at that. But what lies beneath the surface is even more complex and even more critical, and presents us with huge opportunities for engagement. The context really, we are operating in an environment where there's not enough for funding for health. We also do recognize that there are many funding streams, but the question is, how do we leverage those? How do we harness those? But there's a whole issue around leadership and prioritization. Where is that? I mean, are there things that we could do differently around this? And then lastly, how could we do it even more effectively in terms of service delivery? So this is where it's the moment that we are presented with, we are confronted with in the continent. And that is why today we'd really want to see and have discussions around how can we sustainably finance primary healthcare in the context that we're operating in. We do recognize that a number of players have been in this space for long. PEPFAR, USAID, Gavi, Global Fund, government from a bilateral perspective, including multilateral donors, that have been very instrumental in enabling wide access to essential services. But this reliance has also, at times, inadvertently led to dependency. And that's why we need to face this challenge head on. This is the reason why we are here today, so that we begin to look at what are some of the pathways that we need to position ourselves towards. There's therefore a clear and urgent need to tackle these issues. As we say, every challenge begets a big opportunity, or rather, every cloud has a silver lining. We really have a moment as a continent and as players in the health sector to have innovative strategies for getting more domestic money for health. And not just getting money for health, but can we get more health for the money that we have? And really strengthening the foundations of health financing. So essentially, today, just quickly, what we want to achieve today. One is really to understand the impact of funding cuts on primary healthcare in Africa. We also need to explore how stakeholders are navigating this change. And what are the opportunities for innovative strategies to finance PHC? And lastly, how do we collaborate better? How do we advocate effectively for sustainably financed PHC within the continent? And by all means, it may not necessarily be just the continent, but also as part of our bigger shared learning agenda, it could as well benefit other actors beyond the continent. To do this, we have a great team of eminent panelists drawn from different cadres of our stakeholders and operating in different landscapes and geographical areas. One is Dr. Stephen Muleshe, who is the head of the Division of Health, Health Sector Coordination and Intergovernmental Relations, Ministry of Health in Kenya. So it's really great to have you on board, Dr. Stephen Muleshe. And Dr. Muleshe oversees cross-government health coordination and has served as chair of key regional committees, bringing strong leadership in intergovernmental health systems. So his insights would be extremely important, especially speaking from the perspective of the Kenya government, but also the fact that he's actually been sitting in various other key regional committees. Then all the way from Nigeria, we have Dr. Ashiru Adamu Abubakar, who is a technical assistant to the minister, the Federal Ministry of Health and Social Welfare in Nigeria. He's a public health leader with a decade of government and community health experience. And he has contributed immensely to policy and program leadership at the national level. So it's really great to have Dr. Ashiru on board in this very, very important seminar. And then we have Nicholas Oliphant, who is a senior specialist, community health worker programming at the Global Fund. He's a graduate of Tulane University and is an expert in community-based health delivery, and having worked previously with UNICEF and now with Global Fund to scale community health workers at the global level. And last but not least, we have Dr. Musuva-Njoroge, who is a regional director, East and Southern Africa for ThinkWell Global. A seasoned health system specialist with over 15 years of experience. Dr. Musuva-Njoroge champions universal health coverage and leads multi-country financing reforms to strengthen sustainable primary health systems. So it's really great to have you both, Nicholas, as well as Dr. Ann Musuva. Just a quick run of how we will, the run of show for this webinar today. We will have each of our panelists speaking to us over a period of 10 minutes. So 10 minutes, and then thereafter would have an opportunity to ask questions. So we have conversations, if you like, plenary, to answer the questions that you may have brought on board in the Q&A platform. So we will begin with governments, starting with Dr. Stephen Muleshe from Kenya. And then we will follow with Dr. Ashiru Adamu Abubakar. And then we will move on from there. And in this particular section of this webinar, the panelists will be sharing how their countries are responding to the funding shift and working towards sustainable, domestically financed primary healthcare, even in the situation we are finding ourselves as countries. So without much ado, I'd want to welcome, and I'm much more than pleased to welcome Dr. Stephen Muleshe from Kenya's Ministry of Health. Over to you, Dr. Muleshe.
Yeah, so thank you very much, James, for that introduction. You'd allow me to go directly. Am I allowed to project? Oh, sure. So, I've been asked to look at three aspects of this topic. One being, has there been impact of tightening fiscal space in Kenya on primary health care, and how is government stepping up to protect and strengthen primary health care despite these financial pressures? And lastly, what bold steps are being taken to raise more domestic funds and build stronger, more self-reliant health systems? Next slide. Yeah, so just a way of introduction, we know the government of Kenya is keen on ensuring that we achieve universal health coverage by 2030. And so through the bottom-up economic transformation agenda 2022-2027, you can see amongst the top 5 core pillars is universal health coverage. In Swahili, that is afya mashinani. Next slide. Yeah, so just to, again, just look at the pillars of universal health coverage, the human resources for health, supply chain and commodity and comprehensive integrated information system. Sustainable health financing stands out to be very key, and that is what would be the focus of our discussion today. So the government has embarked on robust health sector reforms, basically to be able to contribute towards achievement of the universal health coverage. And therefore, in 2023, there were 4 acts that were enacted. Primary Healthcare Act, which established the Primary Healthcare Fund. And this is purely government funding to support level 2 and 3 of the health facilities, but select level 4. Then we have the Social Health Insurance Act of 2023 that established the Social Health Insurance Fund. And this is contribution from households through premiums, but government paying or funding for the indigent families. And this fund applies from level 4 or from the primary referral facilities to secondary and tertiary. Then we have the Emergency Chronic and Critical Illness Fund, still established under the Social Health Insurance Act of 2023. And again, this is purely government funding, where we have emergency services that are accessible by all from level 2 to 6, but other services are for paid up members from level 4 to 6. There's one more act that is not here, but that is the financing, facility financing, Facility Improvement Financing Act of 2023 that also established mechanisms to ring-fence health funds at all levels of the healthcare. Next slide. So coming to the question about has there been an impact on tightening fiscal space in Kenya? Yes, and Kenya's tightening fiscal space has significantly impacted the primary healthcare system. We have seen the main effects being reduced operational budgets. As such, we've seen cuts in national and county health budgets that have affected the availability of essential drugs, but also maintenance of infrastructure and hiring of healthcare workers. Increased out-of-pocket spending as public facilities experience stockouts and service gaps. Patients are often forced to pay for services elsewhere, undermining financial protection goals. But also dependence on donor funding. It's important to note that with declining donor support, particularly in vertical programs like immunization HIV, has exposed gaps in primary healthcare service delivery, where domestic replacement funding is inadequate. And then to some extent, it has affected the implementation of UHC, given that budget constraints have slowed the scaling up of universal coverage interventions, specifically the community and dependency levels where primary healthcare is the most assessed. Moving on to the next is how is the government stepping up to protect and strengthen primary healthcare? Like I did say, the government has embarked on robust health sector reforms through the 4 new acts that we didn't mention. And key amongst these the reforms under the Social Health Insurance Fund, where the new Health Financing Act aims to pool resources more effectively, including contributions from informal sector to fund primary healthcare. And again, it's important to note here with the new social health insurance funds, it is mandatory for every Kenyan to be enrolled into this scheme, as opposed to what was there earlier on, the NHIF, which was voluntary. Then the ring-fencing of primary healthcare financing. We have seen efforts underway to earmark specific percentages of health budgets for primary healthcare, including community health. These we've seen, I've mentioned earlier, the primary healthcare fund is one of the funds that are established under the new act to be able to ensure that we give a bit more focus and more resources to primary healthcare as opposed to curative. Then scaling up of community health strategy, we've seen that the government is institutionalizing the community health by formalizing and compensating community health promoters. So the community health program actually is a presidential directive, but it's one of the key core pillars of government in terms of ensuring that we achieve universal health coverage. Integrated service delivery, we are investing in integrated primary healthcare delivery, reducing fragmentation and enhancing efficiency by linking maternal, child, and infectious diseases services. Though these a bit of challenges with the integration, but we're looking at more efficient ways to ensure that even the vertical programs where there's been significant reduction in funding from the donors, we can be able to reduce to do with the vertical programs and have them integrated into the routine service delivery. Then the digital health tools, adoption of electronic community health information system has improved tracking and planning. And this is again one of the big four health agendas for government to ensure that all our facilities are digitalized to ensure efficiency in service delivery. Next slide. So some of the bold steps that are being undertaken to raise more domestic funds. So here we're talking of the major reforms that I've already mentioned, including the implementation of a social health insurance fund that is anchored in legislation. And we hope, as we speak of domestic resource mobilization, this is one of our key initiatives to be able to ensure sustainable domestic funding by mandating contributions on risk pooling for healthcare. Then county-owned resource revenue. Counties are being encouraged to enhance revenue generation and earmark portions for health. I did mention of the Facility Improvement Financing Act, or the FIF Act of 2023, that clearly stipulates how those funds may be ring-fenced at the facility level, but also to be able to have a certain percentage earmarked for primary and community health services. We have public-private partnerships where the government is partnering with the private sector in areas such as health infrastructure, supply chain, and technology to reduce financial burden on the state. And this one is becoming increasingly more important, especially in view of the reduced donor funding. Then health financing strategy that clearly stipulates strategies and innovative ways for which government will fund health services in terms of mobilizing domestic resources, but also improving efficiency and ensuring equitable access to primary healthcare. Discussions have started on some taxation reforms in terms of introduction of adjustment of health-related taxes like sin taxes, which are being explored as potential source of primary healthcare funding. So in summary, we're saying despite the fiscal tightening, Kenya has adopted a robust policy mix to defend and grow its primary healthcare system, re-engineered legal structures that support implementation of universal health coverage. We have revenue enhancement, including what I mentioned, bond issuance and tax policies, financing reforms, moving from input financing to output or strategic financing and insurance pools, but also grassroots investment. The Community Health Promoters Program is a big program for the Kenyan government that hopes to be able to accelerate achievement of universal health coverage, coupled with the digitized community care. Then we have efficiency-led reallocations from tertiary to primary healthcare. Next slide. Yeah, so these steps reveal a dual strategy: shielding existing primary healthcare services through financing and efficiency, but also while aggressively mobilizing new domestic resources to sustain resilient UHC-oriented health system. Yeah, so I think that brings me to the end of my presentation, and thank you very much for listening to me.
Thank you so much, Dr. Stephen Muleshe, for your insights, especially from the Kenyan perspective. I'm sure there are tons and tons of questions that will come your way, including where are we in that journey of travel around the various areas of work, including the re-engineered legal structures, revenue enhancement, financial reforms. But we'll park that for the time being and allow the next panelist to speak. So thank you so much, Dr. Muleshe. Even as Dr. Ashiru Adamu Abubakar comes on board, we do all recognize that we have different contexts as countries, knowing very well that the continent itself is very diverse and vast with unique challenges. So I'll now want to welcome Dr. Ashiru Abubakar to shed some light in terms of what is really working in Nigeria. What is happening in Nigeria? Again, another opportunity for us to hear from another government representative. So over to you, Dr. Ashiru.
Thank you so much. Shivani, can I share my screen? Is that fine?
Of course. Let me stop.
Thank you. I've just tried to put down some few slides just to make sure so that the conversation is structured. And so good afternoon, everyone. I will quickly take us through what's happening in Nigeria and then trying to reflect on how has this transformed. Let me on my camera. Confirm you can see me? Yeah, okay. So true to what my brother from Kenya mentioned, Nigeria also is going through another cycle bout of health reform. Just to say that from 1962 to date, we've continued to iterate and make sure that our system evolves and to be able to deliver quality healthcare to Nigerians. And by 2014, we had the strongest legislation that guides how the health sector will serve the Nigerian people, provide some guidelines, some railguards on what is right, and what have you. But then we've not been able to get that up to speed fully. In 2023, when the present minister came on board and after going through a lot of diagnostics to understand what are the issues with the Nigerian health sector, the Nigerian Health Sector Renewal Investment Initiative was designed and approved by the National Council on Health, Mr. President. And at the heart of it is literally having two giant sites. One is the Basic Healthcare Provision Program, and then the other one is the Healthcare Industrialization Program. The basic healthcare provision program seeks to deepen access to care to the most vulnerable in the country, including providing health insurance coverage, stimulating and strengthening functionality of primary healthcare facilities, among others. While the healthcare industrialization program literally tries to make sure that we build and sustain local production of local pharmaceuticals and pharmaceutical products, accelerate transition of Nigeria into a hub for medical tourism, building quaternary healthcare institutions, among others. To translate this initiative, we designed a health sector strategic blueprint, of which the central goal of that blueprint is to save lives, reduce both physical and financial pains, and produce health for all Nigerians. And the blueprint is hinged on 4 important pillars that resonate with our development as a country. One is to strengthen leadership, effective governance, and in that we hope to make sure that we strengthen voice and accountability to the citizens, hearing and deeply listening to Nigerian people to make sure that whatever design and policies we have are citizen-centered. With the second pillar is on effective governance, or effective, equitable and quality health systems, literally the service delivery, strengthening service delivery from health promotion, health prevention, quality service delivery at primary, secondary, tertiary, strengthening health insurance coverage, and strengthening the production and end-to-end, literally, production of human resources for health, whether investing in pre-service institutions, increasing the quota so that we're able to produce and deliver more, and then having policies that will help you out, that will make sure that the impact of health workforce migration is minimized and a lot of value is returned into the country. The third pillar is that seeks to unlock the healthcare value chain through stimulating local production of health products, shaping local market for commonly utilized commodities by Nigerians, so that they end up, we reduce the burden and cost of medications to them, and then strengthening the healthcare supply, pharmaceutical supply chain, to ensure that we minimize the proliferation of fake and counterfeit products in the country. The fourth pillar is on improving health security, especially from the impact of learnings from COVID, Ebola, and what have you, to make sure that we beef up our potential to respond, detect, respond, prepare, and respond to pandemic, but also to make sure that our health system is climate resilient, looking at the nexus between health and climate. But these pillars are based on 3 important enablers of data and digitization to make sure that we are generating reliable, consistent data that is used for decision making. We are increasing the effectiveness of our spend, because we noticed while we are not spending a lot, but there's a lot of inefficiency in the spend. And then thirdly, deepening the culture and talent within the health workforce within the health sector. Because if you all put in this, we're not bringing robots to drive the system, it's the human beings within the system that will drive that accelerated change. But the Nigerian Health Sector Renewal Investment Initiative will be driven through a sector-wide approach, looking at all that has happened in the country. And through the sector-wide approach, we are taking 3 important transitions. First, we realize that Nigeria is a complex entity. 36 states plus the Federal Capital Territory, 774 local governments, all of them independent of one another. And then a lot of horizontal structures that also feel the weight and are rubbing shoulders with the Ministry of Health, among others. So with that complexity, we felt it's important And then, of course, the development partners also that bring their development assistance and what have you. So we felt it's important if we really want to have that's all that we want, principles that will bind us together. And so the principles of one plan, one budget, one report, one conversation, and one voice serves as our rallying point. The second transition is for us to pull better, coordinate better in line with the list, make sure that whatever we're able to pull, we're channeling it through our high priority interventions and areas of priority for the country. I don't want to, so in terms of the questions, has there been an impact? I think before responding to that, I want to say that the shifts that we've seen in ODEs and what have you, to us, yes, they are painful, and we'll talk about some of the issues, but they are a wake-up call to us as a country. And they made us at the point of transition that we are already trying to take back our health system to make sure that we are government-led, we are reducing the fragmentation, what have you. So it's a wake-up call for us on the consequence of our reliance on donor funding. Secondly, we noted that more often than not, the ODAs that come seek to deepen fragmentation and to some extent also undermine country systems and furthering a lot of wastages and efficiencies. And so for us, it made us to pause and reflect and just to see what is it truly we need to deepen and accelerate our progress. So, I mean, couple of figures here. Some of the immediate things, we've taken some steps as government to understand what are the impact of these funding cuts. And we realized that across, there are 5 important areas that were badly hit, the HIV, TB, malaria, immunization, and family planning. And across the board, you see that there are significant movement in terms of either commodities that are not available. We've heavily relied on partners to provide also and no longer coming. Human resources for health, there are over 23,000 health workers that are at risk of losing their jobs because they've been largely on the payroll of the development partners. We do have facilities, over 5,000 facilities that are over the years been supported by ready to stock out in a couple of months, maybe right from towards the end of Q3, Q4 last year, but then shifts that has worsened across HIV, TB, and malaria. And then, of course, I mentioned the human resource for health that are now vulnerable, and we have to figure a way to retain them because they are trained, they are competent, but unfortunately, some of them, their payrolls had some of them have been on the payroll of development partners that are now pulling their fundings. We've also tried to quantify what is the resulting gap that this would give us. And we've noted over $1 billion, for example, over the next 2-3 years would be gaps that we have to contend on addressing as we move on as a country. And when you all pull the numbers of either the funding and what have you, ultimately we are talking about human beings that are at risk. And so we're seeing over 8 million people that rely on Presidential Malaria Initiative not having access to anti-malarials, over 11 million children that rely on SPARC for seasonal malaria chemoprophylaxis, over 1.9 million people with HIV that are likely to lose access to their drugs, over 576,000 women that may not have access to quality family planning commodities, as the case may be. So what are we really doing to step up to protect and strengthen this system? So as a government, as I mentioned, we are already on transition when this came. And so for us is to accelerate and put our house into order. I think the leadership of Mr. President and Honorable Coordinating Minister were key to making sure we are really aligning and focus on what we need to do to make sure that we get out of this mess. First, we leverage on the sector-wide approach structures for coordination to make sure we bring everybody together to do the stock taking and to make sure we are deepening ownership across the board. Second, we've helped to do, we've moved ahead to do rapid impact assessments across all programs to understand what is happening, what are the gaps, what are the liabilities, what is it that we really need to, that is emergency that we need to respond to. And then of course, when we've got that, we now, with the leadership of Mr. President, we identify how do we mobilize immediate response for things that have short lead time that we really need, that are likely to go out of stock, and then to deepen the inefficiencies within the system. So with the sector-wide approach, I just provided the overview of the reform that we're doing, trying to bring everybody together and make sure that we are all aligned. And then as of February, after the deep dives and what have you, we realized that in the immediate instance, we need $199 to fill in immediate gaps. And the leadership, as part of the bold move to increase domestic financing, His Excellency the President approved additional $200 million to be given to the health sector to fill in those immediate gaps. And this also comes with additional a bit, because we did have over 100% and budget increase in budget allocation this year compared to last year. And so that helped us to make sure that we are really on the edge and pushing to make sure that we are, as a system, we're increasing our financing and channeling it to areas that truly matter to us as a government. And we're now trying to see how do we improve efficiency in terms of either our costing, our forecasting of what we want to do, where are the areas of wastages, how do we make sure that we are really getting value for the minimal resources that we have. So some of the bold steps that taken to raise more financing. So yes, this with swap, we're pooling better, as I mentioned in some of the transitions. Within the sector-wide approach this year, from last year to this, with $1.25 billion from different partners. And so what it really gives us when this comes is to make sure that we are really putting those resources to areas that have catalytic impact on our health, on the health outcomes of Nigerians. And we've also costed the necessary as a whole. And we realized that we need about $3.4 billion. So from government, with the additional finance, we are moving closer to ensure that we bridge those gaps. And then, of course, with the sector-wide approach, a health sector compact was signed with all development partners, committing, and the state governors also, committing to key intergovernmental priorities and align their priorities with government to either pool into government or align the expenditure. And I've mentioned the unlocking the healthcare value chain, the value chain, local production of pharmaceutical products, to make sure that first, as we produce locally, they're cheaper and we can now generate produce at scale. And then of course, the president had allocated a number of resources, whether the medical relief policy program, to make sure that we are able to pool, to buy, use government mechanisms that will guarantee volume, to use that to shape local market to make sure we get the resources across the board. And then of course, strengthening effectiveness of our service delivery, ensure that duplications are minimized. We're using minimal resources to generate more. And then with the basic healthcare provision fund for the facilities to make sure we increase the resources going to facility to improve facility upgrade, service delivery. And of course, for the over 20,000 health workers, additional resourcing that we've got from the 1.25 is to make sure that we strengthen absorption of human resources for health. And because of this initiative, the Nigerian government now said, okay, state, we're going to give you these resources as a grant, but we want you to use it in shaping absorption of some of these health workers that will be relieved, among others. So I think these are some of our initial response and the progress made so far in the country. Thank you.
Thank you very much, Dr. Ashiru. I kind of sense the fact that perhaps you need a lot more time in terms of sharing your perspectives. Very insightful in terms of what is really happening in that space. And I'm sure there will be many questions around how we're leveraging on the swap, how we becoming more effective in terms of prioritization, how do we improve efficiencies, but also how do we optimize on HRH. So it's really great to hear your thoughts and insights around what is happening in Nigeria. Thank you so much. I just wanted to switch gears a little bit and begin to look at, glad that we've had perspective from two governments, one from East Africa and another one from West Africa. So would have hoped that we get another perspective from Central and Southern Africa. But be as it may, I think it's really extremely important that we have this. So switching gear a little bit, let's hear from a global resourcing partner, the Global Fund. I just wanted to welcome Nicholas to speak to us around perspectives from the view of a global resourcing partner like Global Fund as well. We really appreciate your insights around that, even before you speak. So we look forward to very insightful insights into this conversation. Over to you, Nicholas.
Great, thanks. Thanks, James. And first, just want to say thanks to Financing Alliance for Health for organizing, and really happy to be here with such a group of esteemed panelists. Some really, really great reflections from Kenya and from Nigeria. Just for me, just a small correction to James' intro. So, I'm a proud graduate of Tulane. Yes, it's a great program where I did my MPH. Also, though, I'm a proud alumni of the University of Western Cape School of Public Health in South Africa, where I did my doctoral work. So big shout out to my friends and colleagues at UWC. And also, obviously, I look a lot different today than I do in the photo that James shared. I think that was like 20 years ago. So James, thanks for making me look younger than I am. I need to update my LinkedIn, I guess. But yeah, now to some questions. I've been asked to talk about a few things. One is, how recent budget cuts and tighter fiscal space have affected the Global Fund, especially in sustaining investments in primary healthcare. So it's a tough one, but I think we can all agree that what is most important is the effect on countries and populations, not the Global Fund or the global health institutions per se. There are literally hundreds of thousands of lives at stake. And so staying focused on that and what matters most is really key. But to answer the question, how has it affected the Global Fund and Global Fund investments? I think yes. Recent budget cuts and tighter fiscal space have indeed affected Global Fund investments. And in this, in turn, impacts countries and populations. The fact is there is significantly less funding in global health all around, and this will impact investment in primary healthcare for sure. And the Global Fund can't fill all the gaps. They are significant, as we saw the gaps for Nigeria summarized by Dr. Ashiru. Those are huge gaps, and it's amazing to see the government of Nigeria step in and fill those gaps so swiftly. Really amazing and impressive. But indeed, our Global Fund GC Grant Cycle 7 allocations are being reduced to adjust to this new reality, requiring PRs to go through a grant reprioritization and revision exercise to safeguard investments in life-saving interventions, as well as health and community systems, service delivery platforms, and interventions that remove barriers to accessing life-saving services. So how this impacts investment in primary healthcare through the Global Fund remains to be seen, as countries are going through the process right now. But we can anticipate that there will be some effect. To be clear, the Global Fund has been and remains a strong supporter of prioritization of investment in primary healthcare and strengthening the health and community systems needed to deliver PHC. Noting that investment in HIV, TB, and malaria services are in fact part of PHC. While also being strong supporters of integration and sustainability. In particular, transition of domestic financing of HIV, TB, and malaria programs. So the Global Fund and the Global Fund funding isn't left out unscathed from the recent cuts, and perhaps no one will be. I think today it's just it is a fact. There's less resources in global health today than there was several months ago, and the outlook doesn't look better in that regard, at least from external financing. And so really we do need to look at the impact on countries and how to best support countries weather and navigate this change. And I think the example that Nigeria has provided, and it was news to me, Dr. Ashiru. So, I mean, this is really, really great news. It's really great to see how countries are stepping up under these very challenging contexts. I was also asked to talk about how Global Fund, were there any adjustments Global Fund had to make in response, and how these impacted support for countries. So as I mentioned, countries are undertaking, as we speak, a reprioritization of Global Fund investments. Some countries may need to reprioritize external funding and even domestic funding beyond Global Fund grants, planning health programs holistically. So we've seen this with the USG funding, for instance. It's happening now with our funding. But reprioritization decisions should be made considering all sources of funding available, domestic and external. So it's really great to see the examples from Kenya and Nigeria where they're taking a holistic view of the situation. The example from Nigeria on the swap and the planning that went around how to adjust things through the swap to cover the gap from the USG, I think is excellent. I was also asked to touch on, as more countries transition to domestic financing, what are the ways funders like the Global Fund can support the shift through co-financing, through technical assistance, or other models. So my thoughts here are that the current events, there's no going back to what the situation was 3 months ago. I don't think. I mean, I think current events really should accelerate the shift towards domestic financing, and I think actors around from country level, also with external funders like the Global Fund, we have to face that fact, I think, or anticipate that things may not be likely to return to how they were before. And so the shift needs to happen at an accelerated pace. The funders can support these kinds of shift, or that kind of shift, in several ways. First, supporting more investment in PHC. This can be done through country-led prioritization processes, like I mentioned, of external funding. So like the one that the Global Fund is embarking on with countries now. And countries have been doing similar work following the cuts from U.S. government. External funding or external investment should align with national strategies, plans, and priorities, including for PHC. This can be through virtual or real pooling of funds. For example, we know that there is a lot of external funding in health that is in inverted commas or quotations kind of off menu or poorly aligned to national plans, and for which governments have little visibility. That really must end. We cannot go back to that. We should not go back to that. That should not be an accepted truth or accepted reality any longer. Funders can also get behind government's efforts to progressively increase domestic funding for PHC. This can be done, for example, through co-financing commitments, support to or cooperating with real or virtual pooled funding, and sector-wide approaches like in Nigeria, supporting blended financing and other government-led financing reforms. Support to government-led resource mapping and expenditure tracking systems, also really key to understand whether indeed there have been increases in domestic financing and whether indeed external financing is aligned to national strategies, plans, and priorities. And of course, this can be done through, external funders can also support technical assistance, but this really needs to be where it's wanted by governments. Many countries, many governments have the capacity and they don't really need technical assistance. They simply need others to not put up barriers or disincentives to increase domestic funding for PHC. So that's my last point on that one, or at least in that first point, is what can funders do to increase funding? Is one of the things is we can avoid being barriers or contributing to disincentives for increased funding for PHC. So getting out of the way a bit. And second thing, so after increasing funding for domestic funding for PHC, we can also support better investment in PHC. Funders can get behind country efforts on integration, for instance, of vertical service delivery platforms and health systems components, the workforce, the supply chains, labs, information systems. There are huge opportunities for integration across vertical programs, as well as functions, for instance, for supervision, quality improvement, etc. So on. All of these things can help lower costs and drive better efficiency, quality, and sustainability. So more health for the money. And just a quick note from the Global Fund side of things in terms of co-financing, the co-financing commitments that were negotiated as part of our Grant Cycle 7, they remain in vigor. They are still in place and are even more critical, perhaps, than ever, to supporting programmatic impact, sustainability of national responses, and this kind of gradual transition from external funding. And James, I don't know if I've got time, but I was asked to reflect on one last thing. Okay, got the thumbs up. So the last thing I was asked to reflect on was, are there any lessons from countries where transitions were successful or where challenges emerged unexpectedly? I think we can look, we don't have to look any further than today's presenters, where they have shared some of the experience, recent experience and examples. Again, kind of looking at the example in Nigeria with the swap and the government coming through with the legislation that has unlocked additional funding for health and for PHC. There have been examples of success in the past. I do also think that we're kind of in an uncharted territory a bit in terms of the scale and the need for a accelerated pace of transition in many contexts. So I think while there are examples that we can point to of success, I think today's context is a bit different in terms of the scale and the speed at which things are happening. So a bit of uncharted territory there. So, we're really looking at a fallout of, a rapid scale and massive cuts in funding globally. So we haven't really been here before. That said, countries know what is needed. They've got experience. The examples today from Kenya and Nigeria are good ones to look at. There are other, examples recently, for instance, in Malawi and Uganda, where governments have stepped up to take on the remuneration costs of CHWs that were previously supported by the Global Fund. And for instance, promising work that is ongoing in Guinea on integrating community health, including the costs for the running costs for CHWs into local government budgets for development, financed by revenue generated through the mining industry. So, the lessons from the past and successful peers will be instructive, but it is largely uncharted territory in terms of speed and scale of change. So I really look to the examples from countries like those shared today, more exchanges of this kind so that countries can learn from their peers. But like I said, I think countries largely know what is needed and how to do it. And we as funders and partners need to get behind them to support them and also get out of the way where needed. Over.
Thank you so much, Nicholas, for your perspectives from Global Fund. The reality that is very, very clear that there will be reduced funding even into the various years to come. There'll be less and less money coming through, especially from an external aid perspective. But then also taken home a number of things that you've spoken to, issues around prioritization and driving efficiencies. And I'm sure there are further questions coming out from the team, from the audience here. But I also hear you speak around how do you get more health for the money that we do have? And just to progress that conversation further, we have Dr. Anne Musuva, who would actually speak to the perspectives, her perspectives coming out from ThinkWell in terms of how do we become more effective? How do we get more done from a health perspective with the less that we do have? So over to you, Anne Musuva, Dr. Anne Musuva, for your very valuable insights.
Thank you, James. Thank you, everyone, and thanks for the opportunity to contribute to this really important discussion. As you said, James, I think a lot of the calls over the past few months, especially since the shifts by USAID, have been, governments need to spend more, governments need to spend more. But we all know the tight fiscal space that most governments on the continent are operating under, especially over the past few years. And so I'd really like to advance the discussion of more health for the money. And so I'll be focusing on efficiencies. How can we unlock more health with the same limited resources that we have? Next, please. So let me just take you a little bit back. So when governments are told, let's expand fiscal space, let's increase the amount of money that we are spending on the health sector, we typically have four main sources of fiscal space. Some sources from the World Bank will say 5, but I would say generally there are mainly 4 sources of fiscal space. The first is domestic resources, and this is where the conversations around domestic resource mobilization come in. And this would mainly be through improved tax administration, basically collecting many more taxes than we do, or tax policy reforms. And this is obviously dependent on the GDP, the growth of the country. So if we look at Africa right now, the tax efficiency on average is between 14 to 16%. That means our tax revenue is about 14 to 16% of GDP. Now, when you compare this to other countries such as OECD countries, that's about 33%, pretty high. In France, it goes all the way up to over 40%. In Asia Pacific countries, it's about 19%. So while Africa may not get to, the 30s and the 40s% and so on, a number of studies show that Africa can actually get to 20%. And so there's some room there to improve the tax that we are collecting to be able to spend it on sectors such as health and other sectors and so on. I think the other critical thing here when we are speaking about domestic resource mobilization is also thinking about the elasticity. So the elasticity in terms of the growth of GDP and the growth of the general health budget. So ThinkWell conducted a study in Uganda last year that showed that for every extra, let's say, for example, if the total health budget grows by 100%, for the health sector, it was only growing by 76%. And so you can see there are quite a bit of inelasticity that actually points to under-prioritization of the health sector within the total government spending. And these are issues that we need to address around the political economy and so on. I talked about the typical economic growth for the country. Now, in countries such as Uganda, where oil is being discovered, Kenya as well, these could be significant opportunities for increasing the resources available. The other potential source of fiscal space is foreign grants. I think we've spoken extensively about the shifts in ODA, in aid. We've all seen what has happened with the folding up of USAID, and we've seen other donors also follow the same direction, pulling out of specific areas in the health sector. And so aid is going down significantly. The other source of fiscal space is debt, basically deficit financing through both domestic and external borrowing. There are a number of many countries on the continent right now are really struggling with a significant debt burden. In Kenya, for example, our debt is 63% of GDP. In countries such as Zambia, it's 115%. And so such countries would really struggle to borrow more in order to fund the health sector. And the other thing with funding as well, especially borrowing, I think it's important to note that when we are borrowing, the focus really should be on capital investments. We shouldn't really be borrowing for recurrent expenditure that is really fiscally imprudent. Although many countries, including Kenya, have actually been doing that. Now, the fourth source of fiscal space is efficiency. And I think this is what I'd like to spend a little bit more time on. And this is where we talk about efficiency in our expenditures, and this is both allocative and technical efficiency that I'll speak a little bit more about. Next, please. Those from Kenya, I see a number of Kenyans on the webinar. I think we are all shocked and dismayed to hear the Minister of Finance, I think about 2 weeks ago, seeking 600 million Kenya shillings, that's about $5 million or so, to destroy 90 billion worth of expired drugs at the National Medical Store. And even though some level of inefficiency is certainly expected, or some level of, let me say, waste and expiries are expected when it comes to the medical supply chain, I think you'll all agree with me that, this is a significant amount of resources wasted and inefficiency. And this picture is seen not just in Kenya, but very many other countries as well. In 2010, the World Health Organization estimated that countries lose about 20 to 40% annually in terms of inefficiencies. And why is it important for us to really promote or talk about efficiency? One of the things that is lacking, and I have to say this in my country as well, is just that there's a trust deficit, People are struggling to pay more taxes because they're asking, where are these taxes going? And so efficiency is really important for government to be able to mobilize additional resources and taxes from the population and to show that, there's actually good stewardship of the health system. And I think it's really important, especially in times like this, where, the global health sector is seeing these shifts in foreign aid, and there are huge gaps that are being left. I think my colleagues have spoken about that. And so it's really, really important, especially now, that governments and we all actually embrace efficiency in how we are spending the limited resources that we have. So when you talk about efficiency, there are mainly two ways to look at it, technical versus allocative efficiency. In technical efficiency, we ask ourselves whether we are doing things the right way. Basically, are we maximizing the inputs that we have to spend less resources and still get the same health outcomes? With allocative efficiency, we ask ourselves, are we doing the right things? Are we allocating our resources in the right way? Are we allocating them to the right inputs in order to be able to maximize the health outcomes that we have? And this is where the whole discussion, for example, of the focus on curative care versus primary health care comes in. This is about allocation of resources. Further, in 2019, the African Union had what we call the ALM Declaration. So this was a big meeting of ministers of health, of presidents, and one of the declarations was that this declaration actually calls for increased domestic resource mobilization for health and tackling existing inefficiencies. So these were some of the two big calls that came about for ministers of health, for presidents, in order to be able to enable African countries to achieve universal health coverage. Next, please. And this is, I hope it's still, it can still be seen. So there are very many sources of inefficiencies within the health sector, but you'll allow me to just double down on these 6 that are significant sources of inefficiency. But we'll also see how perhaps some countries are already, making strides in those and helping us actually unlock efficiency gains. Human resources for health contribute significantly to the total health budget in most countries. In Kenya, where health is devolved, the 47 counties in Kenya spend about 70% of their total county health expenditure on human resources for health. So that is significant. So we absolutely have to pay attention to how efficient we are spending those human resources. I mean, in terms of how efficient we are spending those HRH resources and how much we are getting out of the human resources that we have already. A number of studies show pretty high absenteeism rates in a number of countries. In Kenya, about 53%, and in Uganda, 42%. And what therefore that means is that despite this significant amount of resources that we are spending on human resources for health, we are perhaps only getting about half of the output that we would, because human resources are not always there. But related to that big problem is the fact that sometimes we don't always have the equipment that is needed for the human resources. We don't always have the medicines that are required for them to really be fully engaged at work. And those reasons are all valid. The next issue is around our supply chain, our medicines, especially essential medicines. In the previous slide, I think I spoke about expiries. But on the other hand, there's this paradox where we have expiries in some facilities or in some counties, and on the other hand, we also have stockouts of health of medicines. Studies conducted by ThinkWell in both Uganda and Kenya show that there are supply chain delays of between 4 to 8 months. So from the time a health facility actually orders for drugs, it can take up to 8 months for those drugs to actually arrive at the health facility. Other challenges that we are seeing, and I think these have been alluded to by Dr. Muleshe, is about the limited pooling of resources, where we have high out-of-pocket costs. I think Nigeria is really, on the extreme on the continent, but it's great to hear from Dr. Ashiru to hear about the significant strides that Nigeria is making. But for a long time, out-of-pocket costs have been over 75% in Nigeria, leading really to catastrophic health expenditure. And so we could borrow a leaf from countries such as Rwanda that have managed to have a coverage rate of about 85% with their community-based health insurance scheme. I spoke about allocation and allocative inefficiencies, about primary versus hospital care. I think this is something that we are really struggling with on the continent. But something else that we see a lot of is investments in the hardware. So this is the building of health facilities, and not really focusing or investing in the software, making sure that those facilities run well. So making sure that they're actually well-staffed, that they have drugs, that they have equipment that they need to make sure that those resources are actually being spent well. In terms of administration and operational structures for the health systems, Dr. Muleshe has actually spoken about the service integration that Kenya is actually moving towards to, we've had these vertical programs, a very inefficient way of service delivery, and we are now moving towards integration, which is really a fantastic step. But the other thing that we also see is that many of our health systems are top-heavy in terms of the human resources, carrying out administrative tasks. But the other thing that we see is that we also have multiple institutions that are tasked with carrying out the same function. In Kenya, for example, we have the National Cancer Control Program, we have the National Cancer Institute, we have another cancer organization as well, 3 bodies tasked, with cancer control in the country. So that's hugely inefficient. I think the last thing I'd like to highlight is around data, multiple fragmented data systems, many of these actually occasioned by the vertical programs that we have, leading to suboptimal use of data for decision making. And therefore, performance management programs that really focus on harmonizing the data systems. Dr. Muleshe has spoken about the digital superhighway that Kenya is embarking on, and I think Dr. Ashiru has also spoken to that, are really critical for us to make sure that we are really efficient. We have all our data in one place and we can use the data adequately to make decisions. So in the interest of time, James will allow me to stop there. Thank you.
Wow, thank you. Thank you. Thank you very much, Dr. Anne Musuva. Very, very insightful in the sense that it gives us a different perspective, but also gives us the fact that there's hope, especially when we begin to look at inefficiencies. So once again, thank you so much, our eminent panelists, Dr. Anne, Dr. Ashiru, Dr. Muleshe, and Nicholas. We really, really do appreciate your insights. I think for me, what is profound is in all these contributions and insights is that while we are faced with the reality of funding cuts and the challenges that this presents, there are also very, very clear opportunities to reform our systems, to localize our ownership, and to begin to look at issues around domestic resource mobilization. And equally important, the need to drive smarter and more sustainable investment. So I think it's very clear that even as we look at the challenges that we face, going back again to my earlier point, that for every cloud there's a silver lining, that it is a wake up call, as per Dr. Ashiru's sentiment, is a wake up call. But also important is that there is no single blueprint for solving these challenges, because we all operate in different situations, different contexts. But it is clear that we have there's evidence of growing momentum. There's increased appetite for shared learning, and that there's a collective determination that we can and must build on as different entities and different actors in the spaces that we are in. So it's really profound for me, and there's a lot of learning, a ton of learning for me, especially the experiences that come up from the countries, the experiences from a global resource partner, but also from ThinkWell in giving us insights around the need to be a lot more efficient in how we do our business. But I believe that there are tons and tons of questions coming out from the team, from the audience here. Already I've seen a number, and perhaps we can dig into that a lot more, and then begin to answer those questions.
So maybe if you let me, James. So there's a question in the Q&A box. Maybe we could start there if you
okay.
like.
Yes.
Okay, well,
Maybe you can call it out, and then we will.
Sure, thanks. So Dr. Alice is asking, where she's saying, thank you, Dr. Stephen, for presenting on bold strategies to address financing of PHC. In terms of health products and technologies, which form a significant cost element of PHC and have been traditionally heavily donor funded, are there specific strategies of funding procurement and supply chains system strengthening by Government of Kenya? So that's a question to Dr. Muleshe from Dr. Alice.
Okay, go ahead, Dr. Muleshe.
So thank you very much for that question. Yeah, so I think the presenters who have gone before me also have mentioned the issue of local manufacturing. This is one of the key interests government has to ensure that we are able to be self-reliant when it comes to health products and commodities. And therefore, we are trying to put in initiatives through various strategies like public-private partnerships to be able to establish local manufacturing plants for both use in the country, but also for which the region can benefit. And we are talking of mainly issues like vaccines, but also other medicines like antibiotics.
Thank you, Dr. Muleshe. Maybe I can move on to another question, James.
Exactly. Go ahead.
Wonderful. So since it's Dr. Muleshe himself, I think there's a question in the chat which said by Mohammed, though, please feel free to also raise your hand and share questions or voice it over if I don't do it appropriately. So Dr. Mohammedo is saying, thank you for the rich presentation from Kenya. I'd appreciate if you could share with us the informal sector integration in mobilizing resources, specifically in fundraising for health financing. So how is the informal sector really playing a role, or is there a pathway that you see going forward? And what was your entry considering the unstructured configuration of the informal sector? So basically talking about the challenges of the informal sector and how to bring it together.
Yeah, so thank you very much. I did mention that the current health sector reforms focus moving towards social health insurance, for which the provision is that it's mandatory for both the formal and informal sector. We know the challenge previously has been, contribution from the informal sector, which basically forms about 80%, 70-20% of the population. So the government has come up with a way to ensure, apart from the mandatory nature, but for their contribution, also they are subjected, or households are subjected to what we call means testing, just to be able to assess how much the households are worthy. From that assessment, then they're able to calculate the contribution to the premiums. The other thing is that we've had challenges again because the premiums are supposed to be paid for a full year towards the insurance, but right now we have discussions around premium financing with different organizations so that the informal sector can easily get access to these funds, so that it can be paid upfront and then it can be deducted wherever they seek services. The other issue is that the government has also come up with a Hustler Fund. Hustler Fund is a fund that has been established to offer small loans, but also it's being incorporated into the social health insurance. The informal sector can access this fund for payment of their premiums also, and at no cost, at no interest at all. So this one encourages them basically to be able to enroll for the social health insurance. Thank you.
Thank you, Dr. Muleshe. Those are really valuable insights. Maybe in the interest of time, there are a few other questions, but I don't know, James, if...
Exactly. Yeah, we have one or two other questions. However, we'll be more than happy to respond to those even as we go along. In the interest of time, and I know our time is up, Once again, I want to really thank the panelists. But even before I finish my appreciation, I just want to give each one of them an opportunity, a 1 minute. What is it called? The last point that you would want to make, really. So I would want to ask Dr. Muleshe, then followed by Dr. Ashiru, and then Nicholas, and then lastly, and not least, Dr. Anne. Parting shot, 1 minute.
Yeah, so thank you very much again, James and the team, for organizing this webinar and also inviting myself to be able to give my insights into this topic. Basically, as like I did say, the health sector reforms that are taking place right now are basically geared towards ensuring sustainable health financing. And with the motto in the country is that no one is left behind. So thank you very much.
Thank you so much, Dr. Muleshe. Let's not leave anyone behind. Dr. Ashiru.
So I think also to, as my brother Dr. Muleshe mentioned, truly we appreciate the invitation to speak and to share our modest journey that we've started, and we look forward to deepening that. But I think for us the key insight, and I hope should be the key takeaway for all of us, especially in the South, is to take back our system. Partners, development that bring development assistance are just supporters. They will never replace the country's health system. So if we forsake the country's health system, for them, time would come when they will leave, and it might be too late for us to start all over. For us, we said sector-wide approach is all for us, and we're happy we're making tremendous movement, and we look forward to learning and deepening this. But for us, I think it's the way to go. If we had not put in this when this cost starts coming, we'll deeply be defragmented. We'll be in disarray. But I think we are calm as a country because there is a trajectory that we've already started, and it's never too late. If you missed it, the time to start acting is now. Thank you.
Thank you so much, Dr. Ashiru. It's never too late to start looking at what is it that we can mobilize locally. Nicholas.
Great, thanks, James. We stand with Dr. Ashiru, Dr. Muleshe on the points made. For me, I think Global Fund remains a trusted partner to countries. Our model is built on that partnership from the country up, and we're guided and led by that foundational belief that we work in the interests of countries. We support countries. We're there to stand with you, stand beside you, and definitely not to replace. I think I've heard the question, is aid over and such. I don't think it's over. I think it's different, and it should have been different a long time since, or a long time ago. I think this moment is an opportunity to make that a reality. So last point, as we stand with countries, we look forward to your support in our next replenishment. We hope that is a good one, so that we can do more in standing beside you, standing behind you, getting our investments aligned with yours, and supporting you. Again, countries in the lead and directing, and we are a supporting cast in the actors on the stage. And in the end, we do this for the people on the ground who really need premier healthcare services, including for HIV, TB, and malaria. So I'll just end with that. Thanks, James, and thanks to all for having me on the panel. Over.
Thank you so much. I think the word that I picked from Nicholas is countries are in the lead. and truly are. They're actually on the lead. Anne Musuva, Dr. Anne Musuva.
Thank you, James. Mine is pretty brief. We have to spend better. It's not a luxury that we can afford anymore. We simply cannot afford anything else, and we do not have a choice. We have to spend better.
Thank you so much. We couldn't have gotten to a better place, but to also have that very clear message. Can we spend better? So once again, thank you so much for your insights as our panelists, but as well the insights that you provided today is really go a long way in terms of shaping our conversations going forward. I also want to thank the audience in the room. It wouldn't have happened without you. So really thank you as well, the various questions that you've asked. We would commit to reaching out even to answer those questions as we go along. Now, this webinar is not the end of our conversation. It's just a beginning, because there are many things that are still up. We have an opportunity for shared learning. We have an opportunity to begin also to look at what are other countries doing that we can benefit from as countries. Remember, countries are taking the lead. And therefore, we are here to support each other even as we go along. We'll be sharing the webinar recording with all of us. And I just wanted to ask that please stay connected with us as Financing Alliance for Health through our website, our various social media handles, our YouTube channel. Let's engage. Let's continue this conversation and let's get it to the next level. So once again, thank you so much for your energy and your invaluable leadership in this very important conversation.